Well, good afternoon, everyone. Good afternoon.
I think it's
My name is Ern Larson, and I'm the Dean of the Atkinson Graduate School of Management at Willamette University. And I'd like to welcome you to our Portland Center here at 200 Southwest Market Street. While the core of our school's operations are on Willamette's main campus in Salem, right across from the state capitol, here in our Portland Center, we deliver our part-time MBA, which is called the MBA for Professionals, to students primarily from the greater Portland area. You may have noticed when you come in that the name of our center includes data science. That's relatively new. We share this facility with Willamette's School of Computing and Information Sciences. It's a brand new school, very exciting school on campus, and they deliver their MS in Data Science program here at the Portland Center. And we partner with that school in a variety of ways, including the offering of a joint MBA, MS in Data Science program, very exciting joint offering. I'm delighted you are here for the inaugural event in a new and exciting series called Atkinson Discussions for Our Time. This is the inaugural event. And my vision for this series is to expand our school's work, serving as a thought leader in the community, to give our students additional opportunities to learn critical and timely issues in the management world, and to give them and members of the external community, and that's the majority of the audience today, members of the external community, opportunities to exchange ideas while everyone here learns from experts on these issues. And we got 3 of 4 experts. The 4th one is on their way. They should be here just any minute. So while students are absolutely at the center of our work in Atkinson and at Willamette, we take very seriously our role as a window between the university and the community. And that's the great thing about a management school, is that we are a natural window between the university and the community. So this panel discussion series really takes us to that window. So today's discussion is titled The Future of Healthcare and Disruptive Opportunities to Reshape It. This event is being recorded, and the recording will be available shortly after the event concludes. The recording will be emailed to all persons who RSVP to this event. We have 4 distinguished panelists, and it's my pleasure to introduce them at this time. This distinguished gentleman is Kennedy Hawkins. Kennedy is the current director of Atkinson's Executive Development Center. This center is our continuing education unit in Atkinson. It offers a variety of skill-based certificate programs to working professionals in the region. In fact, some of those programs are actually taught here at the Portland Center. Previously, Kennedy was president and CEO of PT Northwest, a physical rehabilitation services provider for 21 years. He has over 30 years of healthcare experience, and Kennedy organized this panel. Katie Dobler is vice president at Salem Health Medical Group, She completed her MBA in Atkinson and serves on the Atkinson Leadership Council, which is our school's external advisory board. Katie has over 20 years of healthcare experience. The gentleman who is on his way and will be here any minute is Eric Thorson. He's the CEO of Columbia Memorial Hospital. He has over 30 years of healthcare experience. So when he comes in, we'll just have him right on his. You get the hot question. No introduction. Everybody knows about him. And then last but not least, Dave Baden is the interim director of the Oregon Health Authority. And Dave has close to 20 years of healthcare experience. So at this time, I'll turn things over to Kennedy so we can get this panel discussion started. Great. Kennedy, thank you.
Hey, thanks, Dean. Appreciate the opportunity to be here, and also very thankful for this talented group of healthcare experts here. And we added it up. They have over 100 years of healthcare experience between us. And when I started in healthcare, I had lots of hair. So this is what 30 years of healthcare does to you. But thankful for your participation today. And then the other thing too is we're going to talk about where healthcare is at and where healthcare is going and where it kind of needs to go. But if healthcare is going to change, it starts with conversations like these. So I'm very thankful for our panelists, and I'm just going to get at it right here. I'm going to give you kind of what I call as a softball question to start, and it's this. In one word, how would you describe healthcare currently and why? How would you describe healthcare currently and why in one word? Katie, you're up.
Challenging.
Challenging. Why did you say challenging?
Well, I think for those of you in the room that are in healthcare, challenging for recruiting people, retaining people, challenging. So for our providers, that puts a lot of stress on those that are still remaining in practice. Challenging for patients because it really pushes access, and so we don't have access across, not just primary care, but specialty care as well. And so challenging for patients, and then challenging, for people in administration or for systems and independent clinics even to remain financially viable. You read about hospitals closing across the nation, independent groups having to shut their doors as well. And so challenging is the word that I would choose.
Thanks. Dave, one word and tell me why.
Yeah, thanks, Kennedy. Inequitable. I think that the healthcare system that is in the United States just is really inequitable across the board. I think just a lot of the same things of sort of upstream reasons that cause a lot of downstream impact on people that are just trying to improve their health, stay well, be able to, where needed, see a specialist or do that care, and just the outcomes and the inequities that are inherent in the system just create lots of disparate impacts depending on where you live, what you look like, your economic circumstances, whether you have immigration status or not. There's just a lot of barriers on the individual side to be able to access the system, and then the costs of that system on providers and on sort of the whole system at large, and just the burden of having in this country to pay for keeping yourself healthy. And the statistics of in Oregon that healthcare makes up the largest percentage of an average family's budget in the state. More than housing, it's more than food. It's just hard to fathom to think about that. And so, how do we have a system to thrive and help people thrive?
Right. So I would say I try to be optimistic, okay? But I would say it's broken. And I would say it's for the reasons that Katie has said in terms of it's just challenging. She mentioned the labor issue. 20% of the workforce just left over the last 3 years. Okay, they became truck drivers, they became comedians, they became wine owners. And seriously, I had one guy who became a postman. Like, why do you want to become a postman? Because I just go deliver the mail, and it does sound like a lot of fun, but seriously. So I would say it's for those reasons. It's for the reasons that Dave said about the inequities in our healthcare delivery system. And then the other thing too is the economic model is just broken. It is fundamentally broken. It needs to be remade. I mean, we have, like as Katie said, we have healthcare, we have hospitals closing. We can't get access to care. And then the other thing I would do is if you look at the surveys for the American public. Last year was the first year that they said a majority of Americans said they were dissatisfied with their healthcare delivery system. So I use the word broken. Now I think we can come together and fix it as rational individuals, but that's the word I would use. The word is broken. So with that, so I didn't mean to start you with the doom and gloom. There is some optimism here, and there will be an opportunity for questions afterwards. So we're going to leave some time to hear from you and feedback from you. So now I'm going to say, so as we paint the picture of what the healthcare landscape looks like, I'm going to start with maybe you, Dave. And what we have here on the panel is, Eric and Katie are from the nonprofit healthcare systems. Dave is from public health, and then myself, my background is more for-profit healthcare, and then also tied to a publicly traded healthcare organization. So you kind of got the full gamut of the healthcare delivery system. So Dave, let's go to you, and let's talk about what do you see the greatest forces impacting healthcare today as we paint this picture of healthcare?
Yeah, thanks, Kennedy. I think just following along on a lot of this. I think it's. I'll start big and then go sort of in depth. I do think that sort of the trust in entities writ large. So you could go trust in government entities, trust in healthcare, trust in sort of core expertise, and believing that it's true. Believing that there is somebody out there that whether in public health or in healthcare that you can go see, they have expertise. They're going to try to treat you as a whole person, try to help you get well and thrive. I think so much more of our society is becoming more and more distrustful of any of that. I mean, I'll try not to tell too many COVID stories, but I'll do a few. And I mean, I think just vaccines, especially for me, and having a sort of a public health history and sort of what vaccines have done for the world in the last 100 years, and just watching the trust in what those vaccines are, because inevitably it's about public good when you come to vaccines, right? Yes, you want to get vaccinated to protect your own health, but it's about herd immunity. It's about doing something that helps your fellow citizen, American member of the world. And that is breaking down, not fully broken down, but is breaking down. And I mean, the story that really got me, if you go back to when the COVID vaccine was going out, it rolled out in various different ways and various different age groups became eligible. Kids were sort of one of the last age groups that came in. And it was the first time where all kids became eligible at once. There was other times where a subset of kids, depending on sort of underlying conditions, it was the first time that everybody became, so it went from 0 to see what happened from there. It was also later in when there was a lot more concern about vaccine hesitancy and other things. And just watching the differences in vaccine uptake across the state of Oregon was extraordinarily dramatic. You had counties such as Benton County, where Corvallis is, to where the vaccine uptake for, first shot, about half the kids got the first shot in the first 2 weeks. Pretty good. It takes a lot, time out of work, all the things to do that. And then you had other parts of the country or other parts of the state where it was at 1 or 2% for months. So it just, that faith and trust in healthcare and government is, I think, fundamentally a concern. And then just want to double down on workforce, of just the impact of workforce writ large, of people wanting to leave, the impact of violence, and all of the concerns about just being in the healthcare industry and, giving it your all. But then, are you able to go home at night and, just be able to live your life? That's huge.
Right. Great. Thank you for that. Katie, why don't we go to you here? What do you see some of the greatest forces impacting healthcare today?
Yeah, when you set the questions, I was thinking about government and how we get paid, and but I actually want to tee off what you said about inequities earlier, and it all plays a part with, again, CMS lowering rates and practices closing, and you work for profit, and you said it was publicly traded, and we see Optum coming in. Is that who just bought the Corvallis clinic or in the process of buying it? So you see these for profit, and they're not all bad. But
you do indeed.
Yes, I worked at the Portland Clinic before for many years before returning to Salem. But and a not-for-profit organization has to make a profit in order to reinvest in the but those companies oftentimes they can't afford to see government payers, right? And so, and especially smaller ones, they cannot afford that. And so you see this even more inequities where their access is closed to Medicare or Medicaid, and then they're pushing those patients out. Usually systems will see them, but you have to have a good balance of the commercial and the government payers. And so I think that's a huge, actually, one of the greatest forces today impacting how people receive care and where they can receive care. And again, then places having to close their doors because they can't afford to see the patients. With the redetermination of Medicaid, we have people going off it. Does that mean they become uninsured? I don't know kind of where that will all play out. But I think that your point about inequities earlier is a really strong one, and I think that we can't overlook that. We have a hospital in Dallas and clinics, and we see again the for-profit. They're not taking Medicaid patients. That's a big percentage of the population in rural Polk County and West Valley, and so very challenging. And then that also puts the onus, on providers and us keeping doors open, et cetera, too, financially. They just have that disproportionate pyramids.
Thank you. Eric, welcome. And I'd like to hear your perspectives. You've run a successful hospital group there over on the coast. What do you see as the greatest forces impacting healthcare today?
Yeah, I apologize for being late. Totally on me. Not my style. Anyhow, what you're going to hear from me are more perspectives from rural. I have spent my career serving rural communities and absolutely love it. It's been a wonderful career in the rural environment. It's been wonderful to spend that time. I'm from a small town, so being able to kind of feel like you're contributing to that community or a community like the one that you were raised in has been fantastic for me. So my perspective might be a little different. I'm not sure. The challenges, I heard some about services shrinking or curtailing. I have a lot of counterparts who I talk to who are curtailing services in their rural communities. And that has, a tremendous impact on the community at large. Those curtailments are happening because of workforce shortages for the most part. I have a couple examples that I can give you of kind of how fragile I think the state of healthcare is in a rural environment. We recently went through a workforce issue with our CRNAs, our nurse anesthetists. We employ 7, and they're in very high demand right now because of the shortage. Within a 30-day period, we had 4 of our 7 CRNAs give us 60 days notice to accept an employment offer in the urban metro area. That left us in an absolute crisis where we don't have the depth of resources to pull on, other people. We're an independent organization. We don't have the depth to go and talk to a partner or say, hey, can you lend us a hand? It turns into looking for expensive locums positions or locum providers. It looks at, how do we curtail an operating room or 2 while we, search for replacement CRNAs. So that impact of the workforce shortage that's out there has a dramatic impact in these small rural communities who have no depth. Many of our specialties are, 2 providers deep, 3 providers deep. We don't have very many specialties in our communities that say have more than 5 or 6 providers at a time. So you lose one to a more competitive offer somewhere else, and that shuts potentially an entire specialty down. If we were to lose our one and only endocrinologist in our community because she got offered a better deal somewhere else, that community would go without. And then you're talking about drives 2 to 2.5 hours to reach another healthcare facility from Astoria. So that workforce issue is probably the most current, and pressing issue that we face. And then just in general, attracting providers to rural communities is a significant challenge, especially when you're talking about the shortages and the way that wage inflation has driven up the cost of all these providers to come to your community. And then we struggle a lot with mental and behavioral health issues. Our emergency room is really the hub for all things related to behavioral health or mental health issues. And there's just not enough resources available.
Thank you for all of your different perspectives on that one. So one of the themes here is labor. Okay, the labor, remember we lost 20% of them and they just said, we're done. Okay, and there are all these different things that they have in their second career. So the labor, healthcare is a highly labor intensive industry. I'm sure you all have thought about some creative ways to help those shortages. So let's have a conversation on that. Like Katie, we'll start with you.
Sure. So we have really listened to our providers, and we're offering some hybrid positions now. So we wouldn't have done this in the past, right? And we have providers at a provider at each location that works mostly remote, and then a percentage of their time is spent assisting other providers with their in-basket, because they get barraged with messages all the time from patients. So here they're spending their long day in the clinic, and then their pajama time, it's called, is after hours where they're spending it online, responding back to patients. And again, this is causing burnout. And then their colleagues will take vacation or CME, and then they'll be covering their in-basket. And so these providers, will work partially from home, seeing patients online, and then work from home doing in-basket management. And then they'll come in on occasion, say that we have, we have sometimes where many providers get COVID at a clinic, right? And we have one provider or no providers because we have a couple smaller clinics. And so these providers may come in and also see patients in person as well. So something that, again, we would not have done if we didn't have the staffing shortage. Also, in Oregon, I think that it's wonderful that we have NPs and PAs and rules around them that aren't as strict as other states. Now, it can also be risky, right, as well. They're not fellowship trained. Many of them have panels of patients in primary care. So you have to make sure that they have the training because they haven't spent the years in fellowship that an MD does. But I think that utilizing, we have areas, mostly inpatient, but we do use a lot of outpatient. We always have. But on the inpatient side, thinking differently about how do we utilize NPs or PAs to help support like our trauma surgeons, surgeons, and rounding with the patients kind of as that first line, and then escalating up to a provider. So then you don't have to have as many, maybe for call that you did. So really thinking differently, and culturally they have to accept, working as well with an NP or a PA. So that's some challenges that we've overcome, but I've done some really good work. So
let's go to you, Eric. I mean, you deal with this every day. How are you, and what do you see what can we do on the labor shortage here?
Well, at the end of the day, there's just a pure shortage. And so now what we see we're all fighting for the same resources. And, you go back to my CRNA example, they left for a different model. They left for a model that were basically 24-hour shifts, a few days a week, and they could work a total of 7 to 8 shifts in their entire month and make just as much money or more as they were making in our setting, working, 8s to 10s a day, taking call, being the only person, on call and not having any backup. We have to, in the rural environment, then compete against, what's happening in the urban market. So we have to become more creative with how we deploy shifts, how sensitive we are to call, and what we can do to lessen the burden of call, and then compensation. On that day, our CRNAs who remained received almost a $30,000 a year increase, because when we went to look at the market, we saw that our current rate of pay was no longer enough to attract any candidates to even think about coming to a city like Astoria. So we overnight increased our cost, by $150,000 to $200,000 for those that group of CRNAs that will now work in Astoria. And that is happening over and over again. And that's happening in basically every level of the organization that you go, from housekeepers to physician. And it is an incredible time competing and trying to make your offer look like it's the best offer, and then you should move to, your hospital or your community.
Thank you for that. Dave, let's talk to you. You have a public health perspective.
Sure.
You hear about the labor shortage all the time. I'd love to hear from you.
Yeah, I mean, I think I'll sort of hit then, listening to my two colleagues here of around pipeline, right? I mean, we've got to figure out different ways to create new and different kinds of pipelines into the healthcare industry writ large in all types of ways for all types of occupations. I mean, the one that I think I want to focus on first, or is around, and I think you hit it around behavioral health, substance use treatments, and recent work done by OHSU showed, are there providers that in the medical behavioral health space that look like me, that speak my language, that provide culturally and linguistically appropriate services for their needs? The one that is the lowest is mental health and substance use treatment. And if I would take a step back and say, what would the one that I would like to have most of? It probably is mental health or substance use treatment. So we have a huge gap in people being able to find support, especially for their kids, even more so, that are able to interact in the way that meets that patient's needs. So one thing that we've been doing at the Health Authority over the last couple of years is the legislature provided $60 million to provide scholarships, other sort of work study for behavioral health fields. So social workers, other mental health techs, to basically offer full rides and other sort of incentives. And the way we structured the program really tried to incent and provide funds for people of color, for people who, where we know that there are largest gaps in the state. If I would close my eyes and say that it has made a difference today, I can't say that because these things take time. And I think convincing the legislature in my case to keep going with these opportunities, because if you do a pipeline once and you don't continue that investment, you won't have a pipeline. I guess maybe you have a pipe. Yeah, something, a line. So I think that just that continued growth of different ways to fill the pipeline of talent and meet an ever-changing and more diversifying spot that is Oregon.
I think to add on to that, I mean, the pipeline is definitely, I think, the answer longer term. There are more and more, I think, on-the-job training programs starting up in hospitals. We've started a number of programs where we're, paying and supporting staff to advance to the next level, or taking someone, a sterile processing tech comes to mind, an incredibly hard position to find, but a relatively easy position to train into. And so how do we, which we never really ran many training programs, but how do we start to train our community, start to train physicians within our organization? And it's worked pretty well over the past, 6 months.
That's a great idea. You're seeing more and more of that now. We're just going to have to figure this out ourselves. And the other thing I would say, so you're all voters here. I'm not getting into the political fray here, but I go to Capitol Hill every year. I'm on the Capitol Hill lobbying for healthcare issues. Okay, and I've been up there 20 plus straight years. You need to get involved. You need to share your concerns if you have them. And I would say the biggest thing is on that pipeline issue, student loan repayment for healthcare workers. You got to expand it because ultimately you're just not going to be able to get care in certain parts unless you figure out the pipeline issue. So I know that's fraught with political peril, the loan repayment, but I'm just telling you, it costs a lot to go to these professional schools. You're going to have to figure that out. And I think the governments are going to have to incentivize that. So that was my unsolicited political opinion there. All right, well, let's change subjects here. Okay, so we painted a picture of what we tried to give you is, I was thinking about this whole series here today was, we want to paint a realistic picture of where healthcare is at. We don't want to come in and say, hey, this is rose-colored glasses. It's amazing. You're going to hear from me later. I think healthcare is an awesome field to be in still, even with the midst of all the challenges, because you get to impact people's lives every day. You make a tangible difference in their lives, but we have some challenges here. So let's flip the script here a little bit and let's talk about, there's a lot of disruptive technologies going on right now that can really help healthcare going forward. So let's talk about some of those right now. So Katie, I'm going to go to you because I know very familiar with Salem Health and how you operate. Talk to me about some of the disruptive technologies that you're using at Salem Health to make a better healthcare delivery system.
Yeah, so I know that this also could be a touchy subject, but artificial intelligence and Epic, the electronic record, has quite a few innovations around this front. So just recently, we piloted at one of our clinics. I talked about how providers get so many in-basket messages from patients where it could send, we don't send it, but it creates a reply. So it pulls information from their medical record from the past. So someone asks a question and it creates a reply, and then the provider reads it. It's great because it actually starts that. I mean, they can send the whole thing, but they review it and oftentimes make some changes and then send it, to the patient. So we have to have a lot of training around this because we never want anyone to ever just hit send and not read it first, right? And so there's a risk around it, but the providers that have been trialing this love it. And, because it really gathers all these thoughts for them, and then they can go in and make some changes. So they're not starting with just a blank slate for a response. And then when I was talking with our chief medical informatics officer, he shared, I can't remember if it was Stanford or anyways, another institution that's trialing this as well at the same time, because they get on these calls with Epic to discover what's going well. One of the providers said, there's information here that isn't right. But then they actually went back and looked in the chart and it was all in there and they just didn't realize that it was, in there, right? And so it's pulling things, and otherwise the provider has to go in and be digging into the chart. So it's really some really intuitive, great things that are happening there. The other that we're going to start piloting here in the coming weeks is similar, but it's when you go into when the patient enters the room, that Epic will literally just type what you're saying. And I watched a demo of this, and it's kind of a cheesy demo. That for whatever reason, the medical assistant comes in and says, "Your pizza's here for lunch." I don't know why they changed that. But, yeah, literally cheesy. Yeah. And it didn't pick that up and put it in the chart. So it's like smart enough to know, that should not be part of the discussion, which is probably why they chose to do like that, whatever happened. Anyway, or if they talk about their trip to Europe or something like that, that wouldn't get, and it puts it into the right place in the chart. So we're going to be piloting that at some of our primary care clinics and some of our specialty clinics. We've been doing similar work on the inpatient side with our hospitalists, just in terms of it kind of chart scrubbing and pulling information forward, and that's been going well. Also, again, back to that burden of you're sitting there, typing all this out, and how can you help the providers? And it also really helps again with retention, resiliency. We're not doing this to say, see another patient, though that could provide some access because maybe they'll get through their day quicker. But at the end of the day, we want to provide tools so that people aren't so burnt out at the end of their day.
Yeah, David, it's here from you on what you're seeing from a public health perspective.
I mean, I definitely think sort of the expansion of telehealth through the pandemic, especially in the behavioral health field, and just sort of opening the eyes of the federal government payers that actually there will not be maybe as much fraud as they were concerned about in that space, right? I mean, pre-pandemic, a lot of the burden of not going to telehealth was because the payment methods weren't there in place. So, so I think that it seems that most of that should be here to stay. I mean, there's, I think, a lot of federal things that still need to push in that direction. I mean, that doesn't even seem like that disruptive of a technology anymore. I mean, I remember my first job, I worked for a legislator in Missouri. And one of the things we went to, this was in the 90s, was sort of a telehealth video monitor that was like, wow, that's more years ago than I want to say, 25 plus years.
We'll edit that out, Dave.
Okay, thank you. Yes. So yeah, I like the excitement and the disruption of AI, and just I will admit also the scariness and how in healthcare, when you're in the most vulnerable spots in your life, how that is going to be used in a good way.
Right.
And how to assure that, that it's not used to just, again, further further concerns that are real. I mean, the challenges of AI being based on, sort of the core ethos that is the systems that it's based on, is going to make it inherently racist. And recognizing that is there and what we do about that. And it's so cool to sort of think of ways that it can find things in a chart that, yes, an astute clinician could find too, but just those tools that is exciting too. So that one is really like how we as, a society, the governor has a new executive order to really dig into sort of AI in a variety of ways. It's here, but man, it sort of is exciting and really scary for what its impact could be on healthcare.
Yeah, and it's interesting because, the feedback that we get is that the provider actually connects more with the patient because they're looking at the patient versus behind the computer typing, right? And so it kind of brings back to what it was before there was a computer, but yet it's highly computerized in the background.
Yeah, right.
Yeah.
Well, Eric, how about you? So I'm sure you've given this a lot of thought over at Columbia Memorial and disruptive technologies.
Out of the questions you sent, it's one of the only ones that I wrote I'm really looking forward to.
We want the honesty here.
It's the impact
series
that AI might have on the healthcare system, and I think about it from both the clinical standpoint and how it might improve, care, patient safety. But I'm a finance guy by background, so I'm really interested in the revenue cycle and the EHR and how inefficient all of that is, and how it can be used to hopefully modernize the revenue cycle. We are using already the provider brings their phone into their visit and it listens and enters the information into their record, and it works okay. I think I can see a future for that. The biggest challenge with EHRs and the fundamental flaw is that it takes your highest paid resource and turns them into data entry clerks. And it requires you to either have a scribe with them that you're paying for, or you're using your most expensive resource to manage the EHR. So I hope that AI helps that. On the billing and coding side, I hope that it also, like the automated messages out of your inbox, I hope that it provides some enhancement in how we code claims, how that can be automated. And then on the care side, a couple of things that we're working on that I think are really cool. Virtual ICUs. So, the ability, we have a lot of telemedicine connections in our facility now with OHSU. But this takes it to the next level where they'll actually be able to have an attending physician in Portland care for that patient in Astoria through cameras and a robot and that technology that's emerging. So our hospitalists that work in Astoria will have, I hope, a better level of comfort being able to take care of a sicker patient, so that ultimately, at the end of the day, in my opinion, it's all about keeping your community in the community they reside. So if I can make that physician on site feel more comfortable by having a connection to an intensivist in Portland, or have someone even help manage that in the evening time, it will allow us to care for our community in a much better way. So we hope to have a virtual ICU up online in 2024.
Great. That's great. And other disruptive technologies, you're probably wearing one right now. Your Apple Watch, right? It's all right. This is not a paid for Apple, but I have a big Apple. But it'll tell you, like, if you're having a heart arrhythmia and things of that nature, they'll call. You've seen the ads for Omnipod. I don't know if you have any people that that have the Omnipod to manage your diabetes. I mean, it's been life-changing. So I think you're going to see more and more of those type of devices, which will enhance patient outcomes, but also to drive down the cost of care, because that's keeping people out of the most expensive parts of the healthcare delivery system, which is the ER. Yeah.
I'd like to learn a little bit from the panelists on the cycle of innovation, because to your point on the Apple Watch, that's a direct consumer innovation. And I'm really curious what it takes internally to do these adoptions, to have new technology support the care portion of the business?
Yeah, someone want to answer that?
Takes a lot.
You're
welcome to the state bureaucracy without and live the glories of trying to create innovation in a system that still has Pascal-based payment systems for those that had lived in the 70s and 80s to do that. Yeah, I mean, I guess I would sort of look innovation in a couple of different ways. So I would argue the state is not great at technological innovation. Now, I think there are things that we did in the pandemic that were pretty new and had some things that I think we could talk about. I do think that sort of the process innovation and trying to continue to further policy and sort of healthcare access goals, that truly is also innovation too. And it's not the Apple Watch. It's not sort of a technological solution, but I am excited to talk about, she mentioned sort of the redeterminations that we're going through in Medicaid right now. And Oregon has kept more people enrolled in Medicaid than every state but one. Why? It's because we care about keeping people covered. One, the core sort of tenet of the state, and relatively bipartisan in the state. There's less concerns in Oregon about arguing whether people should have health coverage. Not type of health coverage, you could argue about, but just that there should be access to health coverage. So we
And
could,
access to providers.
yes, that's all. But at least the ability that people have some sort of insurance and are less uninsured. I mean, our uninsured rate is less than 4% of the state. So I do think that we're better at that piece than I would, sort of the technological innovations is a struggle. The state is not on the cutting edge on those pieces.
So what I'm hearing is the foundation of the business and the revenue improvements can set a stage for principle to carry over into better care for patients. Like that's kind of the first step of what's.
I also think that, things that are happening around us, like the staffing shortage and crisis, that kind of forces you sometimes to seek innovative ways in which to see patients or change the way you deliver care. So I think that there are just outside impacts that actually kind of force you to go in a direction that you may not have thought of looking at before, because you were working on kind of basic foundational things. You kind of sometimes, not you're jumping to a conclusion, but you're looking for different ways to solve different problems.
Yeah. Well, that helps. If I could do this, because I want to leave a little bit of time, but I want to give them one last question, and then I'm going to open it up to you, and you can fire away at this esteemed panel. So we'll start with Eric down there. What advice would you give someone currently in healthcare or considering a career in healthcare? As we talk about reshaping healthcare for the better, what would you tell them, Eric? And let's do some quick hitters here.
I'm going to give you a quick one. I am positive about the field in general and the industry in general. I think that it is ripe for some change. I think my advice, I'm surprised when I look back from doing this for 30 years. The constant has been change in that 30-year period. There has not been what I reflect on any kind of stable period in that last 30 years. It's been one thing after another. So, I mean, if you are not up for constant change, embracing change, this is not good for you. I think that being skeptical, and again, I think this kind of comes a little bit from my background, trained CPA, trained to be skeptical. But I think you're better served when you ask a lot of questions. Why do we do a process like that? Why are we tackling it like this? And there's a lot of folks that end it just no, this is the way it's been. And you gotta keep asking the questions. Again, I think being very fluent in healthcare finance will only help you. It is so complex, and the people that I see really excel are those who really do genuinely understand finance. And then lastly, it's loyalty. So I don't know how the industry advances when executive leadership on average turns over every 3 to 5 years, and it might even be less than 5 years right now. So I've seen hospitals where their CEO recycles almost every 2 years. How do you ever get strategy, whether it's good strategy, bad strategy in place, if you're going to have a new leader every 2 to 3 years? And so I would challenge everyone that's going into this field, if executive leadership's on your mind, man, make a commitment to stay put and really make a difference in the organization that you're working for.
Great. Great. Thank you for that. Quick hitter, Dave. What would you tell somebody in healthcare currently or wanting to go into this field?
I mean, I think a quick hitter. I mean, I definitely think the sort of the embrace change mindset and sort of doubling down on like asking questions and getting people into a mindset of growth and how that is good for them too. Because it's, like the reaction of, well, we've always done this way. There is some good in that. I mean, it has worked, or at least some way. How do you turn this into where it is their idea and that they see that change in a positive way? And then a very shameless plug of seeing healthcare more broadly, and including sort of the policy and the public health side. Government healthcare can be exciting. Let me tell you, of being on the front end of policy setting, and I think we as a state need to do better and create better partnerships with our providers in how our policies are set, and I think getting people with backgrounds like you're getting into sort of government healthcare is super valuable. We need that expertise differently than what we've had historically.
Great, thanks. And Katie, quick hitter on what you would tell them?
Yeah, I mean, I agree with everything that's been said. Salem Health is a lean organization, and so, and really what you were saying are lean tenants, but really going to the Gemba, so, going to see what's actually happening on the front line, listening to your people on the front line, that will, all of those lean tenants around making problems visible, problems are golden, they're good to solve, asking questions, are all very important, whether you're looking to get into healthcare or you're in it today, and just remembering to be following the lean tenants. I think it is imperative to be able to bring people along on the journey.
And I would just say you're in a great field. I know we've kind of painted kind of ugly, but you're in a great field and you're in a great time. I do not mean that anything. But you're in a great field that changes lives every day. We just have to figure out what this is going to look like going forward to provide better outcomes at a lower cost, and make sure that we're dealing with healthcare inequity, inequalities there, and also making sure that your providers just aren't thoroughly burnt out. And I don't know if you saw the Oregon Department of Employment came out with their employment projections through 2032. What industry was top of the list? Hands down, by far, was healthcare. So you're always going to be employed, but it's going to look different. So I would, with the time we have remaining, I want to open it up to you, to these distinguished panelists. Fire away, leave me out of the hard questions. Okay. All right. Okay, Lance, ready, set, go.
I wanted to build off a little bit of what Eric said and just kind of give a comment, see what you guys think. I feel like one of the more underappreciated and maybe I think the worst job in healthcare is the manager. I think with me as administrator, when I look back, it's been a few years removed, but for the 25 years, as much pressure as I got from the CEO to put onto my manager and the crap that they had to deal with from the physician or the staff, that's such a high burnout position. And I've seen staff leave because of the manager turnover. I've seen providers leave. I've seen directors leave. So I just think the burnout and the care that we have for our leaders, and when they're so disposable, The EBITDA was 1% off, so gotta go, like you're saying, just total turnover is all EBITDA. And then all of a sudden, the CFO is now the new CEO, which 30 years ago, I never would have seen the CFO step in as the CEO. Now that's almost a common thing to happen. So I don't want to, the healthcare crisis is not just with staff, and it's not just with providers, it's also with people trying to lead both of those.
Right.
Yeah, you have to show respect for people in organizations in order to keep them. And again, they're the ones doing the hardest work.
And reward our best nurses, of course, put them as managers, and they fail, and then they.
That's another question for another, sort of another day.
I just wanted.
Okay, what other questions do you have? Kennedy, that's an amazing name, so I just wanted to share that. Thank you.
Yeah, I have a question. I'm a supervisor of a nonprofit organization that serves the chronically homeless. And when we are navigating, because most of the people who come in are medically inclined, they have some type of medical inclination when we shelter them while we're trying to identify housing, they have a lot of medical attention that they need. However, it's almost like a game of hot potato when we are trying to get them to the right provider and get the right care, right? It's a game of hot potato. They're like, I don't know, you guys take care of them. And we're like, well, we're not medically equipped to do those things. So I guess in my mind, in order to serve my community and bring more robust care in the medical field into the organization that I'm working for, would a care coordinator be the best thing to identify?
I love this question. I think that's teed up for you, Dan.
Kenny, I feel like,
Ask this question.
yeah, can you just follow me around and ask this question?
Yeah.
Yeah, I mean, so I will be succinct in my answer and happy to follow up for more. Yeah, I mean, so one of the new things that we are implementing in Oregon, we're one of a couple of states that is really trying to integrate in Medicaid sort of an upstream look at social determinants of health. So we have received over $1 billion to work and do what you were talking about, which was at a local level, try to do better integration between a housing system that's focused, in many cases, small organizations trying to help people that are houseless or close to being houseless, into a medical community, which may have seen them. They may be on Medicaid, especially those that are homeless. But clearly they're not getting all of the medical needs, their medical needs met. So it has always been a very strong red line from the federal government that thou shalt not use Medicaid for. They're dulling that line with Oregon. And we have basically a proof of concept for a subset of Medicaid members to provide up to 6 months of rent, other sort of rental assistance, first and last month's rent, home modifications, et cetera. That is going to involve coordination that the health system and a housing system have never tried to do before. And let's be honest, I don't think we want to recreate some of the same things in the healthcare system with billing apparatus and all of the stuff that it's like, please, Lord, don't put that on the housing system. They will run away screaming. So that is the work ahead of the state and local areas over the next couple of years to try to demonstrate that that proof of concept. And so, estimates of 125,000 Medicaid members across the state could be eligible for this benefit. So it's it has an opportunity to be game changing for the state and then for the country to move more in this direction, that trying to move more whole person, trying to understand sort of the impacts of upstream social determinants of health on people's health. If they get housed or stay housed, they're more likely to see their dentist and not just show up at the emergency room for their services. And this is going to be a bear to try to implement and not make overly complicated. That's the part that if you say Medicaid to my colleagues here, they'll be like, thanks for making it so complicated. How do we do this in a way that allows you as a provider to do your job and not have to get in all of the in-depth charting and other things that has to happen.
Thanks.
We'll see.
Great
And then
question.
access, in
And
terms of
access,
finding
yeah.
providers for them to see.
Yeah, correct.
Yeah.
Yeah, we're gonna have time for one more question and then our esteemed panel here said they would stick around afterwards and answer questions. So we got time for one more question and then the dean will wrap it up here. So,
My name's Claire.
Hi, Claire.
I registered late, work at Legacy Health System. I was gonna tag on to the dialogue here that one of the challenges is just communication, because I'm sure houseless people don't have computers and phones and a way to reach the provider, and the provider likewise, as they're managing their inbox, doesn't have a way to reach the patient. So just being able to tackle that. Another complex issue in healthcare is educating the public writ large. You know, how do you tell them, this is how you gain access? You don't go to the emergency department, go to an urgent care, or you see your doctor sooner. Some of those options.
no, great point, great question.
One of the things that I deal with, to your point, Eric, is finances. I work with a lot of patients that have sticker shock. It is extremely expensive.
Yeah.
And trying to navigate from the point where a patient needs care to the point where their claim is paid. There are, a lot of steps in there where things can go wrong. We have a range of ages of people interacting with healthcare, as well as competency level and intellect level, that makes even a frontline healthcare worker, they may be entering things into Epic that are incorrect, that make some of the AI advances challenging because they put it in the wrong place. So I guess my question would be, how do you address the competency level and communication to everybody to help them understand that?
Yeah, Eric, you want to maybe chime in?
Well, I think it goes back to the earlier question as well. I mean, I just am a believer that it's got to be effective case management or patient navigation as, a foundational element. I mean, I appreciate all the work that goes into the housing discussion and the social determinants of health, but I mean, that's where I remain skeptical. I said, look, be skeptical, right? I mean, I'm skeptical of how that actually works. And I think about a community like ours, where's the housing inventory that we can put people into?
Right.
But helping people navigate the complex system and helping them navigate through the financial barriers and all that is an area where we're just sorely lacking as an industry. There is not a lot of help to do that. And if I could have somebody case manage the people out of my emergency department that don't necessarily need to be in the emergency department, it would save hundreds of thousands of dollars every year in unnecessary care.
I think for competency, AI actually could help if it starts this message and the person who maybe a medical assistant was typing it, you'd have variation across your whole system based on how people know how they learn to communicate with others. And if it actually frames it up for them, I'd actually think that could help create some standardization across an organization in terms of, because right now it's just, they use dot phrases and things, but a lot of free-form typing, right, of all different skill sets. So I think it could be helpful in that way.
Well, great discussion. Hopefully you enjoyed it. And like I said before, hopefully we wanted to create a realistic view of where healthcare is at right now. But also, like I said, it's a great field. We change lives every day. And it's just, how do we make it better on all the fronts that we talked about? And how we're going to make it better is not ignoring the issues, but actually entering into a collaborative dialogue on how we move healthcare ahead, because it impacts every single generation, every single person here in America. So I want to thank Katie and Dave and Eric for taking their busy healthcare professionals. I want to let's give them a round of applause. And I'll turn it over to you, Dean, to wrap us up here.
All right. Well, thank you, Kennedy and panelist colleagues. Let's give it up again for this terrific panel. Marvelous. What a great way of launching this series. So I want to thank, first of all, the panelists for donating so generously their time and expertise and knowledge today. I also want to thank all of you for attending, for choosing to spend the lunch hour with us. We really appreciate it, and we hope you'll come back. One thing I should tell you is that with many of the issues that have been discussed today, there is absolutely a role for higher education in helping out, and in particular, a management school like ours. And one way that we can help is in partnering with providers and partnering with other stakeholders to come up with programming that meets the needs of aspiring healthcare professionals and current healthcare professionals, and also meets the needs of the providers. So we are actually partnering with the Willamette College of Law to co-design a micro-credential skills-based certificate program in healthcare leadership. And this certificate, which when it's done and ready for prime time, will be offered through the Executive Development Center. One of the reasons I'm so delighted that Kennedy is leading the center, because this is new programming that we're going to roll out. And it will be for people that are in healthcare and want to move into leadership positions and need kind of a really high dosage crash course, as well as people who are managers outside of healthcare who want to go into the healthcare milieu, but really need to know about this highly complex industry, perhaps the most complex industry out there in some respects. So our next panel will be on Thursday, February the 8th, same place, same time, lunch is on us, and it will be on a very different topic, corporate social responsibility. More details to follow. The recorded panel today will be emailed to all of you. I think the plan is to get it out tomorrow. So thank you so much for coming. Have a great rest of the day.